Okay, I see we're exactly on time, so we have 26. We'll make a start. So today's session on the expert session is for medical devices, diagnostics and medical equipment, MDDE. I think most of you will have already done this module. It's one of our early ones in the course. Just a few housekeeping announcements as usual for us. Please mute your microphone and turn off your video until you're invited to speak. When we invite you to speak, please unmute and turn on your video. You can ask questions at any time using the chat box, or during the Q&A sessions, please raise your hand and we'll try and get to you. The recordings and the slide deck will be made available to all participants. The chat box is on the bottom of the screen, this little balloon with 3 dots in it. So the objective of these webinars is to give you an opportunity to answer questions. So we say an expert knows all the answers, but you have to ask the right questions, otherwise you don't get meaningful answers. So MDDE is a very large area. We can't cover all of it in one 90-minute webinar. So I'm going to take just 2 aspects of the module, summarize them, and then invite questions. So our agenda for today, we do a first presentation of about 25 minutes. Why is MDDE so difficult? And then the first Q&A session, and a second presentation of about 25 minutes. Do we really need to buy capital medical equipment? By that, I mean, can we rent or lease or pay for service instead? Do we need to own capital medical equipment? Quite a revolutionary concept, although it's gaining quite a lot of ground now for laboratory equipment. Okay, so our starting point is medical devices, diagnostics and equipment. Why is it so difficult? Why is it such a problem? We don't have all these problems on the medicines. And we've got all these excellent guides, all these excellent policies. There are 18 major documents from WHO on how to do it, how to make MDDE work. And they're not new. They've been there for a long time. Why is it such a problem area? Let's start with a few definitions. We start with health technology, organizing the knowledge and skills, devices used in medicine, a medical device, and the key point around this is modifying the structure or function of the body, not achieved by pharmacological, immunological, or metabolic means. Now that sounds a little bit complicated, but I can perhaps give you an example. If we take the contraceptive device, the copper T, intrauterine device, that would be a medical device because there's not a pharmacological or an immunological or metabolical operation. But if I had a similar implantable contraceptive in the same shape, it's a T shape as well, and it's an intrauterine device, but it's an implantable contraceptive that releases a pharmaceutical compound slowly, that's not a medical device. That's a pharmaceutical because it operates by pharmacological metabolic means. So these definitions are really quite important in deciding what is a medical device and equipment or what is not. And then the definition of medical equipment. So take note of these, and these are the World Health Organization definitions. Always the definitions are important. They might seem nothing at the time, but when we come down to disputes and talking in detail, then they come into their own. Well, what's the current status on MDDE? And the answer is not good. This assessment by World Health It's one of the weakest components of the national health system. And the major problem, the root problem, is there's no policies. Most countries do not have a health technology policy. When you look at the bottom of the screen, only 9% of countries have a health technology policy. You think about the national medicine policy, nearly every country has a national medicine policy. But for MDDE, we don't have a policy. Just a few countries have it. But it's worse, because also at the bottom of the screen, we see 65%. So 65% are trying to enforce regulations which they haven't got. It's like the police trying to enforce the law when there's no law. How can you do that? How can you enforce regulations if you don't have any regulations? So we've got bodies trying to enforce without a clear policy, and it makes for a big mess. And we see the impact of this all across countries. Little box on the right there from Benin. Benin should be a lot more advanced with the amount of medical equipment it's received. It's not, because it can't use it. It's not operating effectively. One of the main reasons is there's no policy. There's no activity to tell us how to formulate, how to structure the MDDE. Sorry, I've done that one. Okay. So if we look at the Sustainable Development Goals, yeah, can we go to mute, please?
Yeah.
Yep, okay. If we look at the Sustainable Development Goals, particularly number 3 for health, every one of those sections requires medical devices and equipment. But we haven't got it working. How can we ever achieve the Sustainable Development Goals if we don't have medical devices, diagnostics, and equipment that works? And we don't. We can never achieve the SDGs, the Sustainable Development Goals, with the current state of MDDE. Well, why is procurement supply chain management so important for medical equipment? Because around 70% of medical devices and equipment in low and middle income countries don't work. They're broken. They've never worked. They can't work. We can't maintain them. They're unsuitable for the environment. And why is that the case? Because of undiscerning procurement. We're buying rubbish. Procurement is buying rubbish. It's never going to work in our countries. And that's a hard thing to say. But that's the reality of the situation we're facing. What does it mean? You are requesting rubbish. The users are requesting rubbish. You're buying rubbish as procurement. You're accepting delivery of rubbish. You're trying to commission rubbish. You're trying to maintain rubbish when it's impossible to maintain it. And when it's dead, you're failing to dispose of it correctly. Well, what do we mean by rubbish? What we really mean is it's inappropriate. It's the wrong technology. It's unsustainable. It's not fit for purpose in our environment. Well, is it really rubbish? Well, actually, no. Most of it is perfectly good medical equipment, and most of it is certified to some kind of standard. The problem is, it's no use in our environment. It's not going to work in our environment. Not only are we wasting money buying it, we're wasting money trying to maintain it when it's never going to be maintainable. It's too expensive to operate, and then we've got to pay to dispose of it. Nearly half of the medical equipment and devices we buy in low-income countries don't work. Nearly half the X-ray equipment we buy doesn't work. We've got whole junkyards full. In theory, it's fine equipment, but practically it's useless in our environment. And it's common sense. Would you buy a sports car to be an ambulance for a rural clinic? Well, these sports car ambulances that you see on the screen are perfectly good ambulances. They're fully equipped, they're very fast, and they're perfectly appropriate if you've got a Formula One racing track. But they're no use at all for a rural clinic. They're going to be broken, the axles will be gone within the first day. It's not appropriate. It might be good equipment, but it's no use to us. So why do we keep buying CT X-ray scanners when we don't have a stable electricity supply and we don't have skilled maintenance staff? It's a real problem. And that's one of the reasons MDDE is so difficult. Well, why is it such a problem? And we can split that into two parts, the technical and the management. The technical, first of all, there are around 2 million different kinds of medical device on the world market, into 22,000 generic categories of medical devices. There's about 100 new products every year. It's technically complex. There's more and more computerizations. Almost none of our doctors and clinicians studied electronic computer technology and software management. It's beyond their skills. And we've got few effective technical regulations. The hard reality, the assessment by World Health Organization, is that most countries don't have the financial resources or the technical expertise for these medical devices. That's the technical side. Many of you on this course are pharmacy or connected with pharmacy. How much computer training did you get? Can you program computers? Can you manage the computer for an X-ray machine? It's beyond the skill base. On the management side, unfortunately, we see no political will to address the situation. Often no one is in charge of MDDE and nobody wants to be in charge. There's no policies, there's no procedures, it's a neglected area. There's a strong belief that every doctor knows exactly about every piece of medical equipment. Again, the assessment from WHO, the absence of suitable technology policies is at the root of the problem. Every one of our countries has got a national medicine policy. Very few have a health technology policy. And that's the starting problem. So, health technology policies, about 9% of countries have one. National medicine, the last time the survey was done, it's 80%. I believe it's now over 92% of countries have a national medicine policy. So on the medicines, we know clearly what we're doing, what we want. We've got the essential medicine concept, we've got pharmacovigilance, got everything all there in the policy. We don't have that for the health technologies. Well, why is no one in charge? And here, it's often because of a conflict of different systems. There are two major systems. I call them the UK system and the USA system. It's not quite that clear cut. The UK system is basically throughout Europe. The USA system is basically throughout the Americas. So in the UK system, MDDE requires a coordination group of a large number of specialist players. It's all split up among different players, and they all come together to decide on MDDE. So we have the hospital engineers, who are all qualified engineers, mechanical, electrical, electronic, and they handle the heavy equipment, like steam sterilizers. We've got the electronic engineers, and they handle the stuff like the ECGs. We've got the electrical engineers that handle the power supply for the X-ray. We've got the medical...
One A4 paper, any plain sheet of paper, please.
Yeah, can we go to mute, please? Yeah, if you have any questions, please put them in the chat box. Yeah, we got anything in the chat box? Can you all hear me okay? Yeah, it looks like. Okay.
Yes, sir, we can hear you well.
Okay, then I'll carry on. Okay, so we've got medical physics for X-ray. We've got perfusion specialists for renal, ICU anesthetic technicians, all specialist technicians all coming together, all different parts. Under the USA system, we have one profession. It's called biomedical engineers. Typically, they will have studied 4 or 6 years at university. They're all highly trained and they handle everything in one go. They handle all of these areas together. But there's little recognition of that profession outside the Americas. So we've got two systems. Both systems are okay, but you cannot mix them. And that's the problem, because often in our countries, we've got a bit of a mixture. We've got some people called biomedical engineers, but they can't do everything, all the aspects like they can under the US system. And under the UK system, we're not very good at getting everybody together to all agree. So this conflict between the two systems often makes it a bit more complicated. And we have no central body to try and coordinate all the different stakeholders involved. And we have different management systems. So in the UK, they bring everybody together in this big committee, the doctors, the nurses, all together, because often they're not considered. If I've got a diagnostic, I've got a rapid diagnostic test for malaria, people will go and consult the laboratory. Well, that's very good. Are they going to use it? It's a rapid test. It's probably the nurse and the community health worker that's going to use it, not the lab. So we need to talk to the people who are going to use it. And that's why there's such a big list under the UK system there. Again, under the USA system, the biomedical engineers handle it, but they have to do exactly the same. They have to go and talk to the people who are going to use it, who are going to make it work. Well, what can we do about it? PSM, procurement's not in charge of medical equipment, and it should not be in charge. But it often falls to PSM because we can recognize the problems. We can see all the problems because we're trying to buy the equipment. We're trying to get the contracts to maintain it, and then we've got to dispose of it when it's done. All that falls onto procurement supply chain management. So because we can see the problems, often it falls to us to try and drive the changes. We're not in charge, we should not be in charge, but we can help highlight the problems and push and promote and advocate for changes. So again, on the World Health Assessment, it says all levels need guidance. And that's our key message that PSM needs to take on board. Recognize that lots of people need guidance, not that we have to provide the guidance, but we can assist people to find the guidance they need, because we can see the problems and we're aware of the World Health publications which help solve those problems. So the starting point is a health technology policy, just like we have a national medicines policy. Maybe you can remember that way back in module 1 when you first started the course. So it's essential in this that we focus on health goals. Too often in the health technology policy, people go straight to the technology. I want X-ray equipment. Well, actually, no, you don't. What is the health problem? Health problem is broken bones. Right. I need a way to image broken bones. What's the best way to image broken bones? Is it X-ray? Is it portable cobalt source? Is it other technologies? I shouldn't be going straight to the technology. The starting point should be, what is the health requirement? Exactly the same as we do in the national medicine policy. So we start, what is the health requirement? What are the health goals? Not technology goals, health goals. Then we can look what technology is most appropriate to meet those health goals. So in our health technology management cycle, you can see that procurement and supply chain is about a quarter of the way round the cycle and is just one section. But in fact, we have inputs in nearly every section. We have inputs in the planning. We have inputs to the budget because everybody wants to know what the cost is. We have inputs in maintenance and repair to contract people, buy spare parts. We have inputs in the training because often we have to contract trainers. Decommission and disposal, we have inputs because we're going to have to ensure environmentally sound disposal of the equipment when it's finished. So we have inputs at every level in the cycle, but we are not in charge. We can advocate, we can highlight, we can recommend what needs to be done. So what are the key guiding documents that we have? Policies, human resources, and then a very old document, How to Manage Healthcare Technology, which was written along with myself and many others nearly 30 years ago. But there are clear documents and guidance there. Not that you have to know it all, but you have to be aware these documents are available. You do not have to write the medical device policy. You have to know that we need a medical device policy, and there's guidance documents available to assist countries producing those policies. So what are the fundamental concepts of a health technology policy? We start, what is the disease burden? And already that's a problem, because the disease burden is changing. In low and middle income countries, it's always been infectious diseases. But now, non-communicable diseases are taking over. We're seeing more diabetes, more hypertension. So the disease burden, the health problems are changing. They're not static. And as they change, our policy must react to that. The epidemiological data, so how many of it have we got? So that's the disease. How many cases have we got to deal with? What are the public health needs? Okay, there are road traffic accidents and traumas. I need to treat the patients. That's my public health need. I then get a device list, a list of all the medical devices and diagnostics and equipment that I need. That we call the theoretical medical device list. And WHO has excellent lists of all the medical devices and all the diagnostics and all the equipment that's needed, but nobody knows about them. Everybody knows about the essential medicine list. We all use it every day. We have a national essential medicine list and the WHO model essential medicine list. And there are priority medical device lists available as well, but less than 9% of countries are using them. We then look at the pattern of hospital practice, what skills are available, what clinical practice is available, and then we come up with the real medical device needs. What can I actually use in my environment? What makes sense in my environment? So we start with the theoretical list, and then we end up with the practical medical list. And that's exactly the same that we do with essential medicines. We start with a list of the diseases. How are we going to treat it? We have the treatment guidelines, and from the treatment guidelines, we make the essential medicines list. Well, exactly the same with MDDE. We have what we call the priority medical device list. Exactly the same approach, but somehow we've never been able to bring that forward into MDDE. We've never been able to get it established. We've had it for 60 years under medicines, but we can't get it into MDDE. So we've got these priority equipment lists and the essential medicine list. the essential medicine list, 156 countries all have their own national essential medicine list. Only 9% of countries have the priority medical device list. That's why we have so much problem on MDDE. We're not using the information, we're not using the systems, the same systems that we use for medicines, we're not applying them to MDDE. So WHO has got these publications of all the equipment, just like the essential medicines list. The latest one, of course, is for COVID. What's all the equipment you need for COVID? The medical devices and medical equipment and diagnostics, it's all there. The priority ones. Diagnostics, core medical equipment for reproductive health, for cancer medicine, all there by therapeutic category, just the same way that we do the National Essential Medicine List by therapeutic category. That's all present. Fortunately, they're not being used. Okay, I'm just on 25 minutes. So my part one message is medical devices, diagnostics and equipment has been a neglected area for many years. Procurement supply chain management is not the lead player, but we have a key role to play in highlighting the problems and advocating for improvements. Starting point is always clear policies, just like we've got under medicines. National medicine policy, National Essential Medicine List, health technology policy, priority medical devices. And we need to adopt the WHO priority and essential medical device schemes much more widely. What are we trying to do? We're trying to do the 4 A's: availability, accessibility, appropriateness, and affordability. And by affordability, we don't just mean buying the equipment, we mean being able to operate it as well. Is it affordable to operate? Okay, so on 25 minutes, we have 10 minutes for our first Q&A session. Is there anything in the chat box? Okay. What's the difference between outsourcing and leasing? Coming soon in part 2. Okay. Will we get the slides? Yes, everybody gets the slides. Okay. All right, if anyone has a question, please raise your hand and we'll try and get to you, or type it in the chat box. No questions? I don't see any hands. No hands, nothing in the chat box. Everyone a bit stunned. I've been a little bit hard, haven't I? Okay, okay, Joseph, please go ahead. Unmute and go ahead.
Thank you, Prof, for this very important subject. I just wanted to know whether you'll touch on it, but it's about contracting for this medical equipment. What's the advantages between buying the medical equipment outright and placement contracts, for example?
Coming in about 10 minutes in part 2, okay?
Thank you.
Part 1 is why it's a problem. Part 2 is what can we do about it? Okay. Okay, any more questions? Please raise your hands or just unmute and speak. Okay, there's no more questions. I'll go on to part 2. Probably we'll get a lot of questions after part 2. Okay. Okay, so I've given you a long story, quite hard, about all the problems. Sorry, just excuse me for a moment. Okay. Okay. But let's think. In the 1980s, yes, I'm a very old man, I wrote a lot of articles about medical equipment. And I said that 80% of medical equipment doesn't work. I said, it doesn't work because we're buying rubbish. And we're trying to use too much technology when we should be using basic equipment, and we're not making equipment fit for tropical conditions. Well, now 30 years on, the situation has improved. Only 70% of medical equipment doesn't work. 30 years of campaigning, and it's not changed. It's not got any better. Why is it not changed? Because there's no political will. There's no priority for it. Nobody wants to fund maintenance. Nobody wants to be involved. See, again, World Health and PAHO from Latin America, South America, saying how much equipment is abandoned, unused, never been used because it doesn't work. So our starting point must be reality. It's no good wishing, it's no good hoping for good things to happen. We've had 30 years of training and it's not happened. It's not got any better. So maybe it's time for a completely different approach. Let's first understand why MDDE is so different from medicines. Well, on the big equipment like X-ray, it's often a one-time purchase. Whereas on the medicines, we're buying them all the time. We're buying them every year. On the equipment, there are technology advancements. All the time, there's new equipment, new styles, upgrades coming. On the medicines, well, the majority of the medicines we're using are over 40 years old. We only have about 5% medicines that have been invented in the last 10 years. The equipment, we should be looking at new procurement routes and new procurement mechanisms. For the medicines, the established routes are not so bad. For the equipment, we have to consult with a wide range of staff with all different skills and try and get them to agree. Well, for the medicines, we've got the Drug and Therapeutic Committee. They don't always agree, but they've had plenty of practice working together. And eventually some sort of agreement will come out. For the equipment, we've got these complex contractual conditions. We've got warranty, maintenance, manuals, spare parts, accessories, special consumables. Whereas for the medicines, we got pretty much standard contracts. For the equipment, it's usually long-term, 5 to 10 years. For the medicines, it's typically 1-year contract. So there are big differences between the way we operate PSM for MDDE and the way we operate it for consumables and medicines. Well, what does this mean? Most of the procurement officers will only ever buy major X-ray equipment once, perhaps twice, in their entire career. They might work for 30 years and only buy major X-ray 1 or 2 times. So there's no experience. The people on the tender committee doing the X-ray, the same. They might only do it once or twice in their whole career. They've got no experience. There are 6,000 equipment items for X-ray and 12,000 manufacturers. Nobody knows all of them. Nearly always, you'll be doing the procurement for the first time. And you're going to have to explain procurement conditions to all the people who are involved in the process. It's a lot of work and it's a massive coordination effort. But there are excellent guidelines available from WHO, and there is an ISO on how to buy medical devices, so that you follow an established quality system to buy medical devices. Excellent guidelines, very few people use them. We also have to understand TCO, total cost of ownership. If your country has a global fund grant, you have almost certainly had to do TCO calculations. Now for TCO, we used to use an iceberg as the illustration, but we were told that most people in Africa are not familiar with icebergs, so we've changed it now to a hippo. And like the iceberg, the hippo, you can only just see the eyes and the ears above the water. Most of it is hidden. And it's like that with the equipment cost. We focus on the buy price, but there's lots of other costs that all need to be added in to the total cost of ownership. And if you're doing global fund work, you'll be familiar with how to do that. What about the training costs? What about the maintenance costs? What about the operating costs? All of that has to go in to the total cost of ownership, not just the buy price. Every part of it has to come together. It might be a cheaper machine, but if I've got to pay to retrain all the staff in this machine, is that really a cost benefit? Maybe I'm better off buying the same model of machine we've already got, even though it might be a bit more expensive, because the training costs will be cheaper. What about the maintenance costs? If I have all the same machines, I can reduce the maintenance costs and the spare parts holding. So all of this goes into the total cost of ownership. Well, your country's probably already got a national procurement policy and manual, but does it have anything on medical equipment? When did the survey in 2015, only 20% of countries had anything about MDDE in their procurement manuals. They had nothing about TCO. Does the manual contain alternative mechanisms? Do you have to buy? Can you look at other possible mechanisms of acquiring the equipment? Well, what's the benefit of doing all this work on this TCO and all the rest of it? Well, you could save a lot of money and a lot of trouble. We could standardize the equipment, could save 30 to 50% for spare parts and maintenance. If we buy basic equipment instead of sophisticated, the equipment would work. I would save 40% on underutilized or unused equipment. If I bought equipment suitable for the buildings, I wouldn't have to keep knocking walls down and building them back up again and putting steel beams in. I could save on modifications. If I could foresee the future, then I wouldn't have unplanned costs, because I would be able to know this equipment's going to be obsolete in 2 years. Maintenance staff and maintenance costs, lifetime of the equipment, downtime, because I haven't got preventative maintenance. I'm not cleaning the equipment, I'm not repairing it regularly. Again, 20 to 35% of equipment out of service. So by using this TCO, I can bring a big impact already to the way in which we do procurement. But the reality is we're not getting health technology policies. We're still buying rubbish. Governments are not willing to fund maintenance. No matter how many times they promise to do it, it's not happening. And we're not seeing a big improvement in the amount of dysfunctional equipment that's lying around. Still pretty bad, 40 to 70% after 30 years of campaigning. So let's look a different way. Do I need to own the equipment? Do I need to buy the equipment? Let's recognize we don't have the skills to buy it properly. We don't have the skills to manage the process properly. Are we better off leasing, renting, or buying a service? Generally, it's been dismissed as being too expensive, but that's because we haven't done TCO. We've taken the buy price of the equipment and compared it with the rental. What we need to do is take the total cost of ownership of the equipment, and then compare that with the rental, lease, or buying a service. Well, what's this buying a service? Well, it's if I buy a lab equipment and I do a test, I'm paying for the reagents, I'm paying for the lab equipment. I can go to a company and say, you operate the machine and I will pay you per test. You buy the equipment, you buy all the reagents, I will pay you per test. If the equipment's not working, you don't get paid. If it needs a better machine, it's your problem to go and buy a better machine. I pay per test. Same for the X-ray. I will pay per X-ray image. You buy, install, and operate it, and I pay you for the service. Or I can rent it, I still operate it, and instead of buying it, I rent it. And there are pros and cons to both sides of this. Buy or not to buy? Well, one of the big points is, what is the technology? If the technology is changing fast, it's better not to buy. It's better to rent, lease, or pay for service, because after 1 or 2 years, it's going to be obsolete. Do I want to buy machines now for TB testing, Gene Expert, when I might be doing urine testing for TB in 2 years' time? When I have all these machines that are obsolete. I need to do TB testing, so perhaps I can rent a few machines for a couple of years. And then when the new technology, the lamps are here for TB testing, I'll change over to that. So a lot of the decision is highly technical about lease buy. It's around what's the rate of change of the technology. Well, what about X-ray? X-ray machines have been used for 70 years. Well, yes, but we don't use X-ray film anymore. It's all about imaging now. It's all about computer-generated images. That technology is changing. It's changing very fast. We're using artificial intelligence to scan the X-rays, to identify problems. Should I be buying X-ray machines that might be obsolete in 2 or 3 years' time? Perhaps I'm better renting, and when the new technology like AI comes out, then I'll buy. That's the kind of assessment that has to be made. It's not PSM's job to do that assessment. It's our job to make sure that assessment gets done and to give advice about the cost of buying, total cost of ownership, and the cost of renting or pay for service. The decision will often be a highly technical one. That was the question you asked me, which is better, buy or rent. It depends on the technology. If you're using technology that's not going to change in the next 20 years, then it's better to buy. What's the rate of change of the technology we're looking at? And for laboratory in particular, it's changing very fast. We're moving more and more towards rapid diagnostic testing, which are consumables. So maybe we're going to want less laboratory equipment in the future. Maybe. That kind of decision needs to be taken by large committees with all the players together. PSM has a role of input into it, but is not in charge. But perhaps we can help to encourage people to get the guidance they need to make those decisions. So what does it mean? Purchasing equipment is normally cheaper in the longer term, but that's if the technology is stable. If the technology is changing, then it's better to rent, lease, pay for service. And again, in clinical laboratories, we're seeing a huge rate of change in the technology. So for lab equipment in particular, we should be perhaps looking more towards rent, buy, pay for service. We can give you the example of computer printers. For inkjet printers, many manufacturers will give you a printer if you buy all the ink cartridges from them. Now, most people will say, oh, no, better I buy the printer because you're going to charge me for the expensive ink cartridges. But if you're only doing a little bit of printing, that can be a good option. If you're doing a lot of printing, it's not a good option. So when you ask me which is better, buy or lease rent, it depends on many factors. How much are you doing? If you're at a rural clinic, how much X-ray are you doing? Does it make sense to buy the equipment? Perhaps renting it is more economical. You need to look at all the different factors involved. We are seeing a massive increase in the amount of leasing, renting going on. And there are pros and cons to each of the procurement methods. Of course, if I buy it, I've got a big cash outlay at the start, and I've got a risk of obsolescence. 5 years, it might be completely out of date. Usually, it's got no trade-in value when it is out of date. When it's dead, I've got to decommission it. I've got to pay to destroy it. If I lease it, I don't have to pay a lot of money up front. I can change the lease every 2 years, perhaps, to get new equipment, but the vendors might not be willing to play with me. Unfortunately, many ministries don't have the best track record of paying on time. Reagent rental, that's a kind of pay for service. I pay for tests. Can be useful, can be beneficial where there are not management abilities for the equipment. And again, useful to change in if the technology is changing often. So each of the methods has got pros and cons depending on the specific circumstances. It might be that for central level, it's better to buy the X-ray equipment. Whereas out at the rural clinics, maybe it's better to lease it. It depends a lot on just how much you're using it and what the technology is at each level. Well, if leasing and renting is that good, why isn't everybody doing it already? Well, there are many problems with it. One of the main problems is, unfortunately, many of our governments in lower middle income countries don't have a great record of paying suppliers on time and reliably. Very few companies are going to enter into a lease pay service unless there is really secure payment, unless they feel the government's going to pay on time. And that's not one of our strong points. One of the other problems is I often have obsolete procurement regulations, which are built into annual tender systems. I've got to tender annually. Doesn't allow me to do anything else. That's not really very good for operating a lease rental system or pay for service. So there are real difficulties around using these, but I would say the reality is we've tried buy, and it's not worked. Perhaps we need to look a lot more seriously at rental, lease, pay for service. So that way, maybe we get equipment that works. The difficulty is the government going to pay? So what's involved in this for PSM? What's PSM's role in all of this? Obtain reliable information and sourcing for the equipment and supplies. What's the cost of the equipment? What's the cost of renting it? What's the cost of a pay for service contract? And that's already a big challenge. Most of our procurement units are not familiar with doing that. Consider the different procurement methods. Excuse me a moment. Okay. Then what am I going to do before we get into a procurement situation? How am I going to receive, store, and distribute the goods? If I've got to pay for service, how am I going to monitor it? Normally, the equipment's delivered, I tick the box, sign for it, it's finished. But if I've got pay for service, how am I going to check that that's operating correctly? How am I going to monitor it? Whole new systems now need to go into place. They're all there, they're all in the WHO manuals. How am I going to receive the goods if it's going for rental? How am I going to monitor it all? Again, all the guidance is there in the manuals. So the role for PSM is around the contracting, is around the implementation of the contracts and management of the contracts for these newer procurement routes. But why do you need to be doing all of this? Because we've got a very diverse market. 6,000 types, 750,000 brands, 12,000 manufacturers. Nobody knows all of this. It's difficult to get the information. It's difficult to pull it together. It can be simple items like a hand-operated table centrifuge, or it can be a CT scanner. Nobody can know all of the medical equipment. So it's a massive job to coordinate all the specialists and get them together to agree exactly what's required. Okay, I'm just coming up to time. So addressing medical equipment procurement is a priority. We could solve a lot of problems. We could save a lot of money. Major improvement in sustainable development goals and therapeutic benefits. Starting point is that MDDE PSM is different to medicines. It's not especially difficult or complex, but it does require a total health technology management approach. You do need to consider these alternative procurement routes. Fundamentally, it's a huge coordination exercise, getting all the players together, getting everyone to agree on what they need. That should be the Health Technology Committee. Until we have health technology policies, it falls to PSM to try and advocate and promote the need for all of this to happen. Okay, the second Q&A session, as we are just on time. Okay, let's see what we've got in the chat box. Okay, let's have a look. Okay. How best can technology policy be acquired in low and middle income countries? Okay. Okay, by following the WHO policy on how to develop a health technology policy. They've got a complete guide, just like we've got the complete guide for developing a national medicines policy. It was written more than 20 years ago. It's been updated since then, but there's an excellent guide on how to do it. Doesn't mean that we as PSM have to do it. We have a role to play in it. And our first role is advocating for it, advocating for that policy. Most of our African countries, due to corruption, has been procuring and buying the most expensive equipment, which compromises sustainability. Well, that may be true, but I'll give you another alternative. Many of our doctors, many of our clinicians have trained overseas. They've seen this wonderful equipment, very sophisticated, very powerful. And of course, that's what they want to use. The reality is it won't work in our environment. We don't have stable electricity supply. We don't have stable water supply. For some equipment, vacuum and air pressure supply. We don't have that. We don't have a cadre of maintenance personnel who are going to keep it working. We don't have the support and we don't have the spare parts. So yes, corruption has probably played a role, but more than that, it is demands for too sophisticated equipment. And we have to try and moderate that. We do that through health technology assessments, which I haven't mentioned today because it's rather complex, but it is part of the module on MDDE, we have a whole chapter on health technology assessments. And that's how we decide what is appropriate for our environment. And that's how we address that issue, through health technology assessments. Find it in the chapter. You'll find all the WHO and ADA guides on it. Is there a need to do value for money assessments? Absolutely. And that's the health technology assessment. Whether the right patient or reagent rental, yes, we do that on the health technology assessments. You will see the guidelines there. You will see the guidelines on how to do the cost comparisons on Excel sheets. It's a big challenge. Okay, for the free funded diseases, TB expert, yeah, Gene Expert. Are we going to buy Gene Expert? Maybe it's going to be replaced. Maybe there's a new technology coming. HIV equipment on rental, yeah. Why? Because it's changing all the time. New technology, new systems coming along. So health technology assessments are the way that we do the value for money assessments. Between outsourcing and leasing a product. Okay. Leasing a product, I'm going to pay rental on the product. Instead of buying it, I'm going to rent it. I'm going to pay a rent every month to the manufacturer. I operate the equipment just the same as before, but I pay rental on it. Difference is this: if the equipment is not working, I don't pay the rent. So the manufacturer or the company supplying the equipment is responsible to maintain it. That's the big difference between buying and renting. Outsourcing means I'm going to buy a service. Now a company is going to operate the X-ray machine, and I will pay them for each image. They operate it, their staff, everything about it belongs to them. They buy everything to make it work. So there's a big distinction between outsourcing and leasing. Outsourcing is a service, leasing is a rental. Just like renting a house. I pay each month to rent. The difference is I include maintenance in. So the supplier is responsible to maintain the equipment. That's why I'm paying for the rental. It starts with policy. Yes, absolutely. Starts with the health technology policy. Then we can work forward. What is the best practice? It's up for the country to decide. Rwanda, for example, which is the best system, UK or USA? It doesn't matter which one you choose. That's the health technology policy. Just choose one of them. Both systems have pros and cons. If you're not going to pay to develop a cadre of highly skilled biomedical engineers, then you're going to have to go with a UK system. And these highly skilled, nearly all master's degree people, they're highly skilled, highly trained, and you have to pay high salaries. And if they're not willing to do that, then you have to go with a UK system and have a large committee and try and manage the committee of all the different players. It's no one size fits all. That's why you have the health technology policy for your country. That's why you have the national medicines policy for your country. You make those policy decisions. Leasing and paying as an option initiated by the buyer. Usually it is, but I mean, more leasing companies are becoming more active. So you might expect leasing companies will approach you in the future. They're not very active in low and middle income countries yet. Some there, it is happening. There's some lab equipment increasingly being leased, and suppliers are increasingly pushing for leasing rental contracts. That is happening. So I expect more of it in the future. But right now it's mainly initiated by the buyer. Rapid tests, Barry, is that it should be WHO approved. Yeah, the list is not big. No, it isn't. There are around 6,000 rapid COVID tests. There's only about 30 on the WHO list. Why is there only 30 on the WHO list? Because only 30 are reliable. That's the level of the market. The WHO lists are small because they choose reliability and quality and guaranteed certified quality. There's plenty of rubbish out there. You need to keep to quality items. Tool for the PSO minister? Yes, it is HTA. Most of them don't want to know because they think HTA is too complicated, and it is. HTA is complex. It is technically difficult, but you don't need to do all of it yourself. WHO has done the HTA. It's in the priority medical equipment lists. They've already done it. They've already said what's good for you, what's good for low and middle income countries. You don't need to do all the analysis all over again, just like the essential medicines list. Use the priority medical lists. That's a good start. Okay, we've got just a few more minutes. If you want to raise your hand or enter something in the chat box, I'll try and respond to it. No hands? Okay. Okay, Priya, is there anything else? Have I covered all the chat box?
I guess we have already taken all the questions and we have no further hands. So we can just end the session now, sir.
Okay, fine. Okay, and then I will say good night to all. Thank you for joining us. I'm sorry it's been a bit intense session of saying what all the problems are, but I hope I've planted the seeds of some answers. The health technology policy and the priority medical equipment list. Okay, I've got Jean-Baptiste Yanget has just come through with common theme is advocacy. Yes, that's one of our major roles, advocacy. I've been trained for 30 years, so I now pass the baton on to you to try, and hopefully with these new procurement routes of rental, leasing, and pay for service, or reagent rental as it's sometimes called, we can find a way forward. Okay, good night to all. Thank you for joining us. You will get the slide deck. You will get the recording of the webinar. Any questions at any time, please send them through to us.
Thank you, Prof.
Thank you.
Thank you.
Prof, thank you so much.
Thank you again.
Thank you so much. Thank you. Love your prayer.
Thank you, Prof. Thank you.